Subscribe to our YouTube channel to learn surgery in simple way.
Pancreatic neuroendocrine tumors. How do you classify pancreatic neuroendocrine tumors? Pancreatic neuroendocrine tumor (PNET) are classified as either functional or non-functional. Functional tumors produce variety of hormones which characterize them: insulin, glucagon, somatostatin, gastrin, vasoactive intestinal peptide. However, non-functional tumors are not completely silent. They produce many peptides like pancreatic polypeptide, chromogranin A, ghrelin, neurotensin B, neuron-specific enolase. So what defines functional and non-functional tumors? Functional tumors produce secretions which produce specific symptoms like hypoglycemia by insulin secretion. Secretions by non-functional tumors do not produce any specific symptoms despite their increased circulating levels in blood. Around 30% of PNET are functional tumors. Due to specific symptoms, functional tumors are detected early and hence have a better 5-year survival. Insulinoma. Insulinoma constitute 1 to 2% of all PNET. They are usually small, less than 2 cm in size. Mostly they are solitary, but if associated with MEN1 syndrome, there can be multiple insulinomas. They can be present all over pancreas. They secrete insulin and/or proinsulin. Classically, there is a triad called Whipple's triad, which is diagnostic of insulinoma. Insulinomas are malignant in 10% of cases. So what is Whipple's triad? Patients with insulinoma present with hypoglycemic symptoms. Blood glucose tests done at those times will usually show low blood glucose, typically less than 40 mg per deciliter. There will be rapid recovery of symptoms by administration of glucose or meals. To make diagnosis of insulinoma, serum insulin and proinsulin levels are measured. However, it is best to measure these tests in fasting state as postprandial levels are increased. So 72 hours fasting is done, but usually within 24 hours patient develops symptoms of hypoglycemia. At this point blood sample is withdrawn and sent for insulin, proinsulin. Serum insulin levels may get raised in people on exogenous insulin therapy if they take overdose of insulin. Such cases of over-administration of insulin is differentiated from overproduction of insulin in insulinoma by measuring C-peptide levels. In addition to insulin and proinsulin, C-peptide is formed during insulin production in pancreas. Hence their level will be higher in insulinoma while normal in exogenous insulin administration. Once diagnosis of insulinoma is made, next imaging studies are done to localize the site of insulinoma. Gastrinoma. Gastrinomas are generally found in around 90% cases within the gastrinoma triangle, which was described in 1984 to aid surgeons in finding these frequently diminutive tumors. The extraordinarily high levels of gastrin secreted by these tumors are the cause of the recurrent peptic ulcers, diarrhea, and reflux esophagitis experienced by most patients and cause the thickened mucosal folds in the stomach that are a hallmark of the disease. These presentations are collectively called Zollinger-Ellison syndrome. The majority of gastrinomas are considered malignant, 60%, and have spread to regional lymph nodes by the time they are diagnosed. They are usually solitary except in MEN1 where they can be multiple and more in duodenum. Laboratory diagnosis of the disease requires demonstration of hypergastrinemia and abnormal gastric acid secretion. This can be done by obtaining a fasting serum gastrin and a gastric pH. If the gastrin level is 10 times normal and the gastric pH is less than 2, the diagnosis is confirmed. If results are equivocal, a secretin or glucagon stimulation test can be performed because gastrinomas frequently express both receptors and respond by secreting abnormally large amounts of gastrin to the injected reagent. Glucagonoma. Glucagonomas secrete glucagon, causing hyperglycemia. These tend to be solitary pancreatic tumors. The most common symptoms of the disease are glucose intolerance, migratory necrolytic erythema, and weight loss. The migratory rash tends to start in the perineum and then spreads to the trunk and extremities and is often the first manifestation. Approximately 60% will have liver metastases at diagnosis. The diagnosis is achieved when an elevated plasma glucagon level is found in the context of an enhancing pancreatic mass. On CT they are usually large tumors. Vasoactive intestinal peptide secreting neuroendocrine tumor. These tumors tend to be solitary, intrapancreatic tumors. greater than 50% of which are metastatic at presentation. VIPomas secrete VIP, causing severe secretory diarrhea. The hypersecretion of VIP, a neurotransmitter and intestinal secretagogue, leads to large volume, average 4.5 liters, watery diarrhea. It is also known as pancreatic cholera, also known as Werner-Morrison syndrome, which leads to metabolic acidosis, achlorhydria, and hypokalemia. If not properly identified and treated, patients will eventually succumb to renal failure secondary to hypovolemia. Somatostatinoma. Somatostatinomas have a less defined clinical syndrome than do the other functional PNETs, and not all tumors that hypersecrete somatostatin will cause symptoms. The syndrome may include glucose intolerance due to inhibition of insulin secretion, cholelithiasis due to inhibition of gallbladder motility, weight loss due to malnutrition, diarrhea, steatorrhea due to inhibition of secretion of bile and pancreatic enzymes, or anemia due to malnutrition. These tumors may arise either in the pancreas or duodenum and may be more aggressive if intrapancreatic. They have an association with neurofibromatosis type 1. Non-functional tumors. Non-functional tumors tend to be larger than functional tumors. They cause symptoms usually due to mass effect or may be diagnosed incidentally in ultrasound done for any other reason. If symptomatic, it usually causes abdominal pain, jaundice due to biliary compression, weight loss, abdominal mass. Serum levels of peptides are increased and can be measured. Chromogranin A, pancreatic polypeptide, pancreastidin, neurokinin A, serotonin. Chromogranin A is also of prognostic value. Pancreastidin is recently considered more powerful prognostic marker than chromogranin A after resection. If pancreastidin does not normalize, then it is marker for high risk of recurrence. How is PNET localized? Transabdominal ultrasound usually discovers tumor incidentally. However, sensitivity of ultrasound in detecting small pancreatic tumor is low. CT is often the first modality used to image PNETs because it is valuable for detection of the primary, regional, and metastatic disease. CT imaging should be obtained with oral and intravenous 4-contrast. 4-contrast is important for the detection of the primary tumor and metastases, because PNETs and their metastases tend to be hypervascular and best seen in the arterial phase. However, tumor less than 1 cm may be missed. MRI presents no added advantage over CT scan and small tumors may still be missed. Imaging is critical to clarify the somatostatin receptor status of the disease, and scintigraphy with radiolabeled somatostatin analogs has proven to be a useful tool in diagnosis and treatment determination. It has utility in diagnosis, surveillance and predicts benefit from radionuclide therapy. The original somatostatin analog-based imaging modality is the Octria scan, which uses the radiotracer indium-111-DPTA octreotide. In most centers, these images are enhanced by combining the Octria scan with single-photon emission computed tomography, SPECT, which adds axial three-dimensional imaging to the functional scintigraphic image, greatly improving the diagnostic accuracy. The most modern imaging combines PET with CT using gallium-68. Ultrasound is most commonly combined with endoscopy or used intraoperatively in the localization of PNETs. FDG PET scan is most often used in PNETs when the tumor is high-grade. Patients found to have PNETs with uptake on FDG PET are more likely to have early disease progression than those who are FDG PET negative. How is tumor surgically managed? Indications for resection of PNET are all functional. Symptomatic tumors are resected. Any tumor, more than 2 cm, have more malignant potential is thus resected. Metastatic PNET are resected when complete METs removal is feasible. If surgery is not feasible, then there are medical treatment options available. In medical management, most common drugs used in PNET are somatostatin analogs, as these tumors have somatostatin receptors. Like long-acting lanreotide, these analogs may be combined with radioactive materials, thereby effectively delivering radioactive isotopes to the tumor. Isotopes used are yttrium-90, which emits beta rays, and lutetium, which emits gamma rays. This is also known as peptide receptor radionuclide therapy. Among systemic treatment, most common regimes is temozolomide with capecitabine. In poor differentiated tumors, cisplatin plus etoposide is used. Biologic therapies like everolimus and sunitinib are used in advanced disease. In surgical management, location of tumor decides treatment. PNETs of head and uncinate process of pancreas require pancreatic duodenectomy or Whipple surgery. Enucleation can be done for small tumors of head and uncinate process. For tumors of body and talar pancreas, distal pancreatectomy is done, with or without splenectomy. Distal pancreatectomy without splenectomy is called Warsaw procedure.
Subscribe to our YouTube channel to learn surgery in simple way.